Invite my co-instructors on stage, Dr. Nupur Gupta, Dr. Lomi, Dr. Sunita Chaurasia. Please. So we've got this course in order to give you overview of practical approach and supportive scientific work that we've done to give you a kind of a proper evidence-based approach to decision making. However, we will also cover during the course that the evidence may say something, but you have to be aware that when you're talking about clinical evidence, it is in a particular research scenario or particular subset of cases. So how you apply that in your day-to-day practice. We've taken 4 important areas. One is microbial keratitis or corneal infections, an amniotic membrane transplantation, eye banking and keratoplasty, and limbal stem cell deficiency. So we'll start with Dr. Nupur. Dr. Nupur is assistant professor in cornea and refractive surgery services at RP Center AIMS, and she will be covering the management of corneal infections. Mic is on? Yeah.
Coming to this course, and we would be now reviewing some of the newer evidence and of course the established evidence in management of corneal infections. The talk would be involving all types of keratitis and then summarizing the challenges and way forward. Viral keratitis, as we all know, can be caused due to herpes simplex virus or the herpes zoster adenovirus or cytomegalovirus and other multitude of viruses which are upcoming. And so the most common keratitis that we encounter is the herpes simplex keratitis, which is the most common, and the diagnosis usually is clinical in our day-to-day clinical practice. But if we have atypical presentations and if the patient is not responding, we may go ahead with doing a polymerase chain reaction or an immunofluorescence or a viral culture as part of some trials, or also as in the clinical setup if and when needed. In these cases, the compliance and follow-up is the most important thing. If the patient is compliant and complies to the treatment, usually we are able to manage the recurrences. But if the recurrences keep on happening, it hampers the quality of life. Then we need to look for precipitating factors. And the main management pearls for herpetic eye disease is basically guided by the 2 trials, which were the HEADS 1 and the HEADS 2 study. Which the clinical implications of which were involved 2 trials. So the clinical implications were both on all morphological types of herpetic eye disease. The epithelial disease, they said that only topical acyclovir is good enough. For stromal disease, topical steroids. For endothelial disease, oral acyclovir and topical steroids together will lead to better outcomes. And for prophylactic uses, you will need to add oral acyclovir twice a day for an year, because that was the time duration of the trial. However, after the HEADS trial, there have been other trials which say that even topical jancyclovir is good enough to treat epithelial disease. For stromal disease, oral acyclovir has a role, though HEADS study said there was no role because there could be some presentations wherein we have a stromal disease, but it is actually shadowed or not being picked up. The endothelial disease is not picked up in there may not be a purely stromal presentation involvement by the virus. And in the prophylactic cases, you can for herpetic eye disease, you can use oral valcyclovir 500 mg OD also. So just to go over a few cases, which some with typical presentation, some with atypical presentation. This is a case of an hepatic epithelial keratitis, which shows a characteristic pattern of the dendritic ulcer, and with the bulbous ends, the fluorescein has stained. So for this patient, a topical acyclovir ointment, 3% 5 times a day, is the standard treatment. You have to give prophylactic antibiotics and cycloplegics with lubricants. However, if you treat this patient with topical steroids, you will get this presentation, which is a geographical ulcer. Because now the dendrites have coalesced to form of epithelial defect, which is a geographical ulcer. So, topical steroids should not be used in case of an epithelial keratitis. If you have a stromal involvement with the epithelial keratitis, please first treat it with the topical acyclovir or a topical antiviral. Add on steroids later when the epithelial disease has taken, because it leads to more activation of the virus at that site. This is another case, a 33-year-old gentleman who had undergone penetrating keratoplasty for healed keratitis, which was probably viral in nature. You see a recurrence even after 2 days of the surgery, which and you could see the descemet folds, the pigments appearing, the increased corneal thickness, which responded to oral acyclovir 5 times a day, topical acyclovir ointment, a prophylactic antibiotic, and cycloplegic with lubricants. Topical steroids were withheld till the ulcer healed, but we could add on oral steroids for systemic immunosuppression in such cases. This is another case with a different presentation. There is a stromal melt with a very large dendrite, which was treated the same way, and an oral acyclovir helped in this case. Another atypical presentation of a recurrent viral keratitis in this patient post penetrating graft, wherein we had a melting of the graft host junction with differential thinning, and the other eye showed a vascularized corneal opacity, so the patient had bilateral keratitis. The stromal component of a hepatic eye disease is actually treated with a topical corticosteroid and topical cycloplegic with full dose of acyclovir, oral acyclovir, which is continued twice a day for an year or beyond, depending on how the patient responds and depending on the recurrences that he develops after the first incident. This is another case where you can see the Wesley's immune ring in this patient. Treated the same way, you have a differential thinning of the stromal involvement and the endothelial involvement, so you have to give oral acyclovir along with topical steroids and cycloplegics. This is a case which was talking about where you have a mix, where you have both the epithelial involvement and the stromal involvement. In such cases, you have to treat the epithelial involvement with the topical acyclovir, withhold topical steroids, and you can give oral acyclovir and oral steroids if needed. But the oral acyclovir can affect, and when you have the ulcer is healed, then you can start the topical steroids for faster resolution of symptoms and signs. Another case of marginal viral keratitis with an epithelial defect, stromal lysis, and stromal infiltrates, which again responds to oral acyclovir and copious lubricants, withdrawal of any epitheliotoxic drugs, and steroids have to be started later. So the next presentation, which is fulminating and where you have an active viral replication, is the necrotizing viral keratitis, which needs to, though you will have to manage surgically, but before that, institution of full oral dose of acyclovir is important, along with cycloplegics and topical steroids. Here, anti-glaucoma therapy and then a tectonic PK, or if you have a smaller perforation, a glue BCL, or even you can graft it with an optical grade tissue so that they have better outcomes. But the full dose of oral acyclovir during the preoperative and the perioperative period is important for better outcomes. So this is another manifestation of a pure endothelial disease with a disciform viral endothelitis with focal corneal edema. Another case with a linear involvement with linear endothelitis with pigments and Descemet's fold. And you can have a bilateral diffuse endothelitis with increase in the corneal thickness, and the trabeculitis and the iridocyclitis associated with the viral disease need to be treated. So anti-glaucoma therapy is an important constituent of this regimen. Another case where you have the Descemet's folds, there is no epithelial defect, but only the stromal and endothelial. So here, oral acyclovir with topical steroids is a mainstay of treatment. So in all these cases of stromal and endothelial disease, oral acyclovir for 14 days and then for prophylactic days for another year or more, topical steroids with adjunct therapy of topical antibiotic, topical cycloplegics, lubricants, and anti-glaucoma therapy is important for treatment of such cases. Another manifestation of hepatic eye disease or a long-standing sequelae, you can have neurotrophic keratitis. Here you need to withdraw all the epithelial toxic drugs and give more of oral drugs, and you have to give copious lubrication, non-preserved lubricant drops, or you can give autologous serum, platelet-rich plasma. You can have nerve growth factors like senegenum, oral vitamin C, doxycycline, depending on what case. If the ulcer does not respond to maximal medical therapy, then we may have to do an amniotic membrane graft or a tarsorrhaphy in such cases. So coming on to herpes zoster keratitis, here you can see the diagnosis is purely clinical. You have the involvement of the trigeminal nerve of the vesicles on the skin, and if the tip of the nose is involved, you would usually see the involvement of the cornea. So here you have a case with corneal stromal lysis, some pigments, and also some vascularization. So this is treated with oral valacyclovir, 1 gram thrice a day for a week, or oral acyclovir 800 milligrams 5 times a day, along with topical therapy, including topical acyclovir, prophylactic antibiotics, cycloplegic, and lubricants. Steroids again are withheld till the epithelial defect heals. Another case, just to show the difference between the dendritic ulcer, it does not have this epithelial keratitis of zoster, does not have the typical dendritic pattern of a herpes simplex virus, and the terminal bulbs are also missing. Another case of a keratouveitis with herpes zoster. And this is an elderly gentleman where you see a perforation. So this has to be, with the medical management, we have to do a tectonic keratoplasty along with. So this is all guided by the zoster eye disease study, which is still ongoing, and it is actually studying the role of prolonged suppressive valacyclovir treatment, 1,000 milligrams orally for an year, where it reduces the ocular complications and the post-herpetic neuralgia. So this is another child with a varicella zoster infection. The typical skin lesions were seen, and she was then treated with a tectonic keratoplasty and full dose oral acyclovir according to her weight and age. Coming on to adenoviral conjunctivitis, it presents, as we all know, it's the most common conjunctivitis, but it may have a corneal involvement in forms of subepithelial immune infiltrates. The guide to treatment is that we need to manage it properly. Basically, the diagnosis is clinical, but in atypical presentations, when we need to know strain in epidemic keratoconjunctivitis, or in case of a recurrent disease, there is no response, we may go ahead with some tests, which are rapid immunofluorescence tests or viral culture. There is a rapid adeno detector available for such cases. Such a case can be treated with a copious amount of preservative-free lubricants. It is known that the stabilized oxychloro complex with the oxychloro ion has antiviral properties, and it helps in faster resolution of symptoms. But if you have subimmune infiltrates which are active and involve the visual axis, you may need to give steroids, but the steroids are known to increase the recurrences. So the other options are you can give povidone iodine with steroid, which have been shown in trials to have lower recurrence rate. The other alternatives are topical cyclosporin, cidofovir, and ganciclovir. So the important things in management for any adenoviral conjunctivitis is a prompt management, the treatment of dry eye, increasing the local and systemic immunity. So dry eye needs to be managed, and the judicious use of topical steroids, and they may have a hypermetropic shift, so you may need to give them newer refractive corrections in such cases. This is a typical clinical presentation of a cytomegalovirus keratitis, which shows coin-shaped keratic crespi, sometimes which are linear, and you do have a corneal edema with them. Though the consensus on the management of CMV endothelitis is not there, but the further trials were done, and it showed that ganciclovir gel and systemic antiviral therapy, along with topical steroids, do have a role. However, using only topical corticosteroids is a risk for increasing the recurrence in such cases. So a word about COVID keratitis. There have been some reports where ganciclovir ophthalmic gel has been shown to be effective. And we did have a case of bilateral keratolitis following a COVID vector vaccine, recombinant viral vector vaccine, and which was managed by a tectonic keratoplasty. So coming on to bacterial keratitis, we all know it is to be treated with with a combination of fortified antibiotics depending on culture sensitivity, given 1 hourly, then 2 hourly, depending on response. You have to supplement it with the topical cycloplegics, anti-glaucoma drugs, and topical corticosteroids. By the trials have shown that you can start after the ulcer shows a response after 48 hours of starting antibiotics, but still the decision is on the hands of the treating physician, and the results are equivocal. Systemic antibiotics are indicated in cases of a large ulcer, ulcers with scleral involvement, with endophthalmitis, which are perforated, when you are dealing with patients who are either children or elderly, and in patients who have had a corneal graft. So this is just to show the response of a fortified antibiotic, which leads, this was a 67-year-old diabetic, but with controlled sugars and on fortified antibiotics, it healed completely to form a vascularized corneal opacity. But you may have to manage surgically some cases which shows perforation. Depending on the size of the perforation, you can do a glue BCL or a patch graft or a therapeutic keratoplasty. Cochrane reviews have shown that PAC CXL has again equivocal role, but it can be tried in patients which are refractory to management. Coming on to fungal keratitis, as we all know that it depends on the organism, the most common organisms being filamentous fungi. First, natamycin is tried, and if there's a good response, that's fine. Otherwise, you can add voriconazole. There is a TST protocol, so depending on the response, you may go in for a or addition of an oral antifungal, or you may eventually go in for a therapeutic keratoplasty. So this case is like fungal keratitis, you need to debride it. That is one. If there's a plaque formation on the epithelial surface, give natamycin and prophylactic antibiotic with cycloplegics and anti-glaucoma medication. The oral antifungals may be added in the severe ulcers and with scleral involvement. So this is a very small ulcer caused by an alternaria species which responded to just topical natamycin and homatropin. So the decision to treat a fungal ulcer is also guided by a MUT trial, which is MUT1 and MUT2. MUT1 was voriconazole versus natamycin, and MUT2 was addition of oral voriconazole. However, the point to note is that it is for Fusarium species, and it was shown in this trial that natamycin was better to treat voriconazole, but this is for Fusarium species. Shall I go on? So, and the addition of oral voriconazole there was no difference in the rate of corneal perforation. So, but there was another study to show that topical voriconazole can be useful adjunct to natamycin fungal keratitis. Just the difference here was the cases were aspergillus, whereas in the MUT trial, the maximum amount of cases were Fusarium. So this is a typical case of fungal keratitis with an endothelial involvement and a plaque with endothelial involvement. So a therapeutic keratoplasty was done for a non-helial cornea which did not respond to maximal medical therapy. Just to complete the picture, the acanthamoeba keratitis is then the standard of treatment is initially giving hourly round-the-clock PHMB or chlorhexidine or propanidine, but this should be at least continued for 3 months following treatment, or maybe 6 months, because the cysts do not go away and the trophozoites may remain. And the surgical treatment is sometimes because they are refractory to medical treatment if not treated early on. So penetrating or a therapeutic DALC may be needed in these cases. So in all this, what we gain is that the upcoming challenges to treating microbial keratitis is an antimicrobial resistance. We do not have a point of care diagnosis, meaning that if you do not have a microbiological setup at the point, because we all know that infectious keratitis occurs at the rural level, and in the primary eye care level, you do not have a microbiological setup. So having a diagnosis at that point of time and care is important. So the primary eye care level has to be strengthened so that there's an early referral and networking, and prevention is definitely the key for such cases. Thank you.
Thank you, Dr. Nupur. It was a very extensive topic, but you have nicely highlighted the important features, including practical case scenarios. With that, we come to another area which everybody is very familiar with, amniotic membrane transplantation. Dr. Lomi is going to again encapsulate in practical terms what are the applications and give you practical tips as to what is currently known as what are the best scenarios and what are the best results that you can achieve by this treatment.
Very good afternoon to you all. At the outset, I would like to thank my teacher, Professor Radhika Tandon, and the AIOC organizing committee for giving me this opportunity and the platform to present this this lecture. I'll be speaking on empty membrane transplantations. So I have no financial or conflict of interest any in this presentation. So the learning objective of this presentation will be a little bit of genesis of empty membrane transplantation, the biological properties, the preparation and storage of the of empty membrane, the risk application methods, the indication and recent advances. So a little bit about the history background of empty membrane. It was first recorded use in 1910 by Davis by using skin transplantations, and was popularized. First ocular application was used by D. Roth in 1940. So there was a gap of around 60 years between where the empty membrane was used again by Batley for congenital defect. Most probably because of this risk of transmission of infection, or maybe the better preservative media was not available during that time. And the later it was popularized by Kim and San in 1995 for the ocular surface reconstruction. So the biological properties of empty membrane is that it is the innermost layer of the placenta, as we all know, and basically it has three layers: the epithelial layer, the basement layer, and the stroma. And the basement layer is most tensile, and then layer where it give the whole integrity of this empty membrane, and it has got this collagen type 4, 5, 6, 7, and fibronectin and laminin, and the stroma part, which produces the various growth factor like fibroblasts, hepatocyte, and transforming growth factors, which stimulates the epithelialization and modulation, further cause proliferation and differentiation of stromal fibroblasts. And also it suppresses various various inflammatory cytokines like interleukin 1A, interleukin 1-2, interleukin 8, and also have the risk factors like protease growth inhibitor factors and all. So the mechanism of action is it acts as a pro-epithelializations, anti-inflammatory, anti-neovascular, anti-fibrotic, and also a very substrate for cell growth. So it has all these factors has helped that the transfer of this from the wound, the biological tissue to the wound. So here's a short video how empty membrane is prepared and is cryopreserved. So basically, that empty membrane is taken out from the plant cesarean section while collaborating with the gynecology, and you have a proper eye bank setup. The patient, the pregnant mother is well screened of all serological tests is done, all HIV, VDL, all hepatitis virus has been screened. And this is followed by the removal of the placenta, and then it's bring to this to the eye bank in the lamellar hood area through the very aseptic measures. It is cleaned by balanced salt solution, and also with some cocktail of antibiotics. So once it is bluntly dissected, you can see the thin membrane of the empty membrane is peeled off, and it's cleaned well with and all the debris and all the clothing has been removed. After that, it is placed on the nitrocellulose paper and on the various and cut in various shape according to the utilization of the endpoint. So after that, the tissue is transferred to the media. There's the Dulbegos Eagle's eye medium, along with this glycerol in a concentration of 50% in 1:1 ratio. And they have cocktails of antibiotics there like streptomycin, penicillin, amikacin, and also amphotericin B also. So after preparing this one, they store in this media, and then the tissue bottle is kept in a deep refrigerator, cryo-freeze in -80°C. And after that 3 months time, again the surgical test has been done for the mother to rule out any surgical positive test, which we have done it so that to rule out any window period time also. So after that, it is dispensed for the use to the user end. So various application methods has been explained. One is the inlay transplantation, where the amniotic membrane is placed with the epithelial cells upward. So basically, it is used as a dressing, temporary dressing, wound dressing, and it's covered or also used as a single layer or multi-layered to fill the scaffoldings wherever in the ocular surface is there. And only is like with epithelial cells downward to protect the defect area. And a sandwich is most commonly used where the scaffolding area is filled with this empty membrane, and then followed by the inlays, the onlay transplantation. So various indication has been is there for the use of this empty membrane, like most commonly chemical or thermal burns, the persistent corneal epithelial defects, some corneal ulcers, reconstruction of conjunctival ocular surface, various diseases like Stevens-Johnson syndrome or ocular pemphigoids, and also some bullous keratopathy. So here's the case of acute chemical burns where empty membrane transplant has been used and has shown a very good result in 1 month time. So studies at RP centers also, which is published in Beijing by Professor Radhika ma'am and his group and her groups. So it has shown that in grade 4 and grade 5 of Duas classification, where it has shown a very remarkable results in terms of the rate of epithelial healing time, which is significantly better as compared with the standard medical therapy alone. There's another studies which shows the efficacy to compare between umbilical cord serum drops and then empty membrane transplantation in grade 4, 3, 4, and 5 Duas classification presentations, which also shows that the mean complete epithelializations between the cord serum group and empty membrane transplant group are comparable. However, in terms of the corneal clarity, better pain control and avoidance, umbilical cord serum has better effects. However, there is no difference in the symbiotic formation in all these 3 groups. This case of neurotrophic ulcer refractory to the normal convention treatments. So here the sandwich technique has been applied, empty membrane has been applied, and we see the good results, and the patient is now ready for the corneal transplantations. Another case of corneal keloid here after excision, there's a good result following use of empty membrane. In case of persistent epithelial defect, you can use for this empty membrane both inlays and onlays, and we see a very good results in a month time. In case of bullous keratopathy, where you are not intended for any dissect or demake because of the poor visual prognosis, and here you can use empty membrane to relieve the pain or also to maintain the integrity of the ocular surface. Another important utility is in ocular surface tumors, where it's been shown to have a very good response after, and then less recurrence is seen in case of using empty membrane. Here, in case of this congenital melanoma case, where we have done excision, and then after that with cryo and empty membrane transplantation, you see very good results. So far, there's no recurrences we did. And then even in case of ocular surface common neoplasia, you can see a very good results with post-excision followed by an AMG. A case of giant OSSN where like more than 6 clock hours has been involved by this nodular ulcerative OSSN. Here we have done the excision and the post-op at 2 months. We have shown a very good results. Here, I want to emphasize again the utility of empty membrane. Again, since we all know the component of empty membranes, they have various factors: anti-inflammatory factors, anti-fibrotic factors, angiogenesis factors. Apart from that, the transparency of the empty membrane, it helps to see if there is any residual or recurrence tumor are there, which can be assessed in the follow-up time also. So another important utility can be in the case of contractile socket, where it can be used as a furnace formation, and we can give a very good cosmesis following utility of this empty membrane. In case of small corneal perforation, less than 6 millimeter, you can use empty membrane to seal the perforation, where empty membrane is cut in very small pieces, where you can use multi-layered of empty membrane, and then you can glue using a fibrin glue, or you can use a suture and place over it, and followed by the onlays of empty membranes, which can be sutured or you can glue it again. So it has been shown to be useful in case of especially aqueous deficient disorders, and we can easily avoid it when there is infection is still there. Next is the simple limbal epithelial transplantations, which we know that is first described by Dr. Virendra Sagwan in 2012, where after this after describing this slide, there are many papers we have validated and its efficacy in restoring the ocular surface, renewing the corneal epithelium, and also avoiding the reconsolidation of the cornea. So here you see a donor clear limbal area. That donor limbal cells has been harvested around 2 into 4 millimeter thickness, and then recipient bed, all the panels and has been removed and clear off. All the debris have to be cleared off, and followed by you can place a onlay over it, empty membrane, and it is sutured and followed by a glue is applied, and then after that, this donor harvested limbal stem cell can be cut in very small pieces and away from 2 mm away from this limbal area, and avoiding the visual axis, you can glue it and followed by BCL applications. So here's one case of limbal stem cell transplant has been done where post-chemical injury, again here after SLED, we can see a very good result here. One case of SLED which I have done here, in this case there was a bleeding, the hematoma formation was there. So in this case, either you can wash it, if it's not coming out, it's not clearing out, then you can wash it with, make a small hole over it and make it wash it, or otherwise with medication, with time it also started resolving. And we see in this case at 4 months time, it's a very good results following this SLED also. Another is cultivated limbal epithelial transplantation, which is introduced by Dr. Pellegrini and group in 1997, where is utilized especially in case of bilateral limbal stem cell deficiency, or where only 1 to 2 mm of the healthy limbal is harvested and is expanded in the laboratory. So, but the drawback is that you need a sophisticated laboratory for it, and also it's a 2-stage procedures. So here's one case where post-chemical injury, this CLED has been done, and it is shown a very good, remarkable results. So some of the recent advances of utility of empty membrane is empty membrane extrait drops and an empty membrane extrait. So it retains the growth factor activity. So it enhances the wound healings and by decreasing this, by preventing this fibrosis, and also inhibit the scarring formations, and also it promotes the wound healing and regenerations. So there are various studies which have shown the efficacy of this empty membrane extrait eye drop, but still it is not FDA approved as of now. Next is the non-surgical applicable of empty membrane Procera. It is a cryopreserved empty membrane which FDA approved in 2003, and the Schaeffer Sang company have offered this dispensing of this product. The device can be inserted as an office base or in daycare procedure itself, and the advantage of it is it has both the biological and technological benefit of empty membrane. It's as a small 2 ring. Inner ring is around 60 millimeter. The outer ring is around 21 millimeter. They can directly place over it. Or many people have now innovated by using the small Ral's tube of the infant Ral's tube. Also, you can place it, or you can use contact lens over it also. So to conclude, the structural integrity, transparency, and elasticity of the empty membrane makes it currently the most widely acceptable tissue replacement for ocular surface reconstructions. And the characteristic properties of biological properties of empty membrane is help at every stage of the wound healing. And the key of successful empty membrane transplant is a meticulous selection of both the donor and the recipient, and also maintain a high standard of quality assurance. The future innovation is on Procera and empty membrane extrait shows that there's even more good to be derived from the amnion for the eye. And then I would like to acknowledge Professor Radhika ma'am and Dr. Vanati for giving me some of these patients' pictures and also the videos, and Professor Sujata Mohanty from our stem cell facility for providing and helping us in this journey, and Professor Bhavnachala ma'am for all the support and help, and my SRs SRs for their contribution indeed. Thank you all for your kind attention.
Thank you very much, Dr. Lomi. It was a very nice, comprehensive explanation of the basic physiology and the practical applications of amniotic membrane transplantation. Thank you so much. We now come to a very important area. So, any corneal practice, you have to be very closely integrated with the field of eye banking and keratoplasty. So, who better than Dr. Sunita Chaurasia, who's looking after the RIEB at LV Prasad Eye Institute? She requires no introduction, and she's going to give you an insight into a little different story of the evidence-based applications for eye banking and keratoplasty.
Thank you, Madam, for the kind introduction. Now, I'll be restricting to the donor characteristics, which is of relevance to keratoplasty to corneal surgeons. Now, in terms of eye banking, there are several areas of controversy and real-time
I'm showing,
questions.
excuse me, this laptop slides are not showing yet. This laptop has to be connected to the screen.
Yeah, all right.
Thank you.
Thank you. So there are several areas of controversy and real-time clinical questions which may come in eye banking and dealing with real-life situations. For many, we have policy, procedures, and guidelines into place because of the cornea donor study, which are benchmark studies. But for some, we have to go back to our basic medical knowledge and observations of clinical practice to apply them in eye banking. Now, when we say good quality pays rich dividends, this is most applicable to keratoplasty because a good quality donor cornea is paramount to achieve the desirable outcome after keratoplasty. In terms of safe corneal practices for donor cornea retrieval, it is the evidence says that when we use povidone iodine 2.5% for 5 minutes, this is best measure to prevent the post-keratoplasty infections. And one should also avoid the donors which are at high risk for subclinical infiltrates and contaminations, mainly the ones which come from ventilators of more than 72 hours and confirmed sepsis. Donors' medical history is very relevant. We have to rule out medical contraindication, which could be infections. Serology tests are very important for ruling out HIV, HBsAg, HBC, and syphilis. However, for COVID-19, it was never a mandate. Malignancies, in terms of systemic malignancies, lymphomas, and leukemias are absolute contraindication, and so are the intraocular malignancies. Certain systemic diseases affect the corneal donor endothelium, which are chronic kidney disease patients, donors, and the diabetic mellitus, which are uncontrolled because of severe other reasons, several reasons. So these have to be looked into account when we are planning for transplant with these corneas and cornea donors. Donor cornea evaluation involves the salient parameters which is important is corneal endothelium, stromal characteristics to rule out scars and arcus, epithelial status, corneal folds, stress lines, scleroderm. All these are important in the present times of lamellar keratoplasty. The criteria for suitability of an ideal donor parameter will vary with the type of keratoplasty, and with the popularity of lamellar and component surgeries has expanded the utilization of the donor pool, and tissues with poor endothelial health and older age could also be utilized now. When we talk about the anterior lamellar keratoplasty, one should look at the tissue does not have a significant arcus. There is no stromal pathology because many of these cases will be requiring a graft, larger grafts also. And for keratoconus, it is also important to select a donor which is slightly older, more than 25 years, because there's no way we can rule out keratoconus in the donor. Anterior lamellar keratoplasty for just when we are planning for dystrophies, which are something like TGF-beta induced dystrophies, which are based upon the abnormality of the keratoepithelium gene. It is important to select the donor corneas with intact epithelium because these will give a chance for better epithelial survival and later recurrences in these dystrophies. Donor epithelium is also important for indications where the limbal epithelial health is poor and for large grafts to preserve the limbal region at the time of keratoplasty. Now with PK and EK, we know that endothelial parameters are the most important ones. And this slide shows the longevity of the graft. These were the PK grafts done 30 plus years ago. And we have the specular imaging counterpart to the clear cornea. Now, what determines the long-term survival? Now, there are various studies which talk about the graft survival in PK. So there are several studies which quote the long-term survival being 5 years is 69%, 62%, to best as 90%. Now, there are several factors which influence the long-term graft survival. The most important in best-case scenarios is the endothelial health of the donor at the time of transplantation, which determines the longevity. Now, let's look at what is the normal rate of cell decline. Now, in a normal person, the rate of cell decline, endothelial cell decline is 0.6% yearly. Now, but when we look at the PK data, this is from the long-term PK data studies. PK data long-term shows that between 3 to 5 years, there's a cell loss of 7.8%. Between 5 to 10 years, it's 4.2%. Beyond 10 years, it is 1.8%, meaning that how do we interpret this data? So when we look at the post-PK endothelial cell loss, it is 13 times more in the first 5 years, it's 7 times more in the next 5 years, and 3 times more after 10 years, which is never what we see in the normal, which means that there's an accelerated endothelial cell loss in post-transplant patients. So what is the bare minimum arbitrary ECD to factor this endothelial cell loss, the accelerated cell loss which happens in PK grafts? So this data comes from Armitage, where we see that in the prediction model, so there are two exponential components. One is the rapid phase of cell loss, and second is the slow aging phase where the cell decline happens. Now, with this prediction model, we see that more than when you have a cell count of more than 2,000 cells per millimeter square, these corneas, these PK corneas, will have the potential to last for 30 long years, which is the best case scenario. Of course, grafts don't survive that long, but then with the count of more than 2,000, there is a potential for the graft to survive for 30 long years. So that is why for the PK data, we take the arbitrary minimum as ECD more than 2,000 with the phakic donors. Now, what about the other transplants, DSEC and DMEC? Now, when we look at the endothelial cell loss pattern in PK, DSEC, and DMEC, the 5-year cell loss and the 10-year cell loss is sort of comparable across the various types of keratoplasties, which means that when we talk about the arbitrary minimum for the DSEC and DMEC, now because there are more steps in graft preparation, staining is needed, manipulation is required, we may extrapolate from the PK data. We have to factor that also into account, and that is why the bare minimum ECD for DSEC may be around 2,300, and for DMEC, considering staining and all, will be around 2,500. Now, when we talk about the assessment of endothelium, ECD is one parameter, but ECD is only the morphological assessment of the corneal endothelium. The limitation is that there's no way of having a functional assessment, and which is not a practical approach in the eye banking. So what do? There are other parameters which also affect the corneal endothelium. We need to be reminded of these parameters. And what are these? Most of these are related to the death to excision times. Now, in hypothermic preservation, the death to excision times is same as the death to preservation time, overall preservation times, and the impact of age. So there are variable studies which talk about the effect of D2P times on the corneal endothelium. Some studies have quoted that the larger and longer D2P times of more than 14 hours were not associated with any clinically meaningful reduction in donor ECD, infection, and primary graft failure. Similarly, there were many more studies to support this. Now, let's look at the cornea donor studies, which are the benchmark studies in keratoplasty. So D2P times in the cornea donor study with refrigeration were less than 12 hours. Without refrigeration were 8 hours. For the CPTS study, it was less than 20 hours, and without refrigeration was 10 hours. Now, the third source is from the European eye banks, where they take up to corneas which are 24 to 72 hours with refrigeration, and without refrigeration is less than 12 to 24 hours. There's a variability in the practice patterns. Our practice patterns are taking into refrigeration to account is less than 24 hours when the body is refrigerated up to 6 hours. And without that is less than 9 hours. This is based upon the study which we implemented at our eye bank. Now, what is about the overall preservation times? Now, with different preservation solutions support donor corneal and endothelial health to variable periods. Now, within the cornea preservation solution also, there's an endothelial viability which reduces gradually with preservation, and this is a time-dependent deterioration. So what is the effect of overall preservation times of endothelium? With respect to the CPTS study, the data says that there's no effect in graft success with the preservation times up to 11 days. But when we look at the endothelial cell loss 3 years, which was was greater with the longer preservation times, but this is like with the 0 to 7 days was 37%, and 40% which with 8 to 14 days, which is sort of acceptable. What is the effect of preservation times and the post-keratoplasty infections? The studies from the US say that there's a correlation of post-keratoplasty fungal infection with longer preservation times. Now, in our setup, we use more of MK medium, which is a short-term preservation medium. So we have seen that the risk of fungal infections is low simply because of the reason that the tissues get utilized beyond the time period of 3 to 4 days, and which is the reason why we don't see so much of fungal infections compared to the US practice patterns. What about using the aged donors? Now, DMEC has generated a lot of interest in the older donors, and we can use these corneas, and this data has come from Dr. Basak, as long as the endothelial health is good, and this is what we were also practicing. Now, this is just to substantiate this evidence. This is a patient who had a therapeutic keratoplasty with an 86-year-old phakic donor, which had a good transplant, and this patient till date is doing quite well. Now, impact of age and graft survival in terms of the evidence from the cornea donor study, we see that at the 5-year survival, graft survival was 86% with the donor's age between 12 to 65 years and was similar between 66 to 75 years. The 10 to 12 years survival was also sort of comparable, but the age effect was seen at the extremes of the age group. There was a 96% survival for between 12 to 33 years and 62% survival for the donor corneas between 72 to 75 years. So how do we apply these evidences? So one of the important things is that when we do a transplant, we have to do matching of the donor parameters with the recipients in terms of age, indication, and the type of surgery. We should consider the age of the recipient and consider the age, the graft lifespan to the life expectancy of the recipients, meaning that we may not be very choosy about older recipients, but we have to be little particular about the patients in the pediatric age group where these evidences can be applied to the selecting the donor parameters. Now, with respect to DSEC and DMEC, there are a few criteria which are important. Now, there are two methods of donor preparation. Some of us do the manual dissection, and the IBanks do the automated method. The success of graft preparation requires a good size and regular scleral rim, and that is why when we are harvesting the donor cornea, it is important to have a good scleral rim in the donor corneas. The donor tissue parameters which are selected, as we discussed earlier, was more than 2,300. Ideal would be 2,500, but that is also okay. And age group should be about 10 years. Though there's no upper age limit, some of the sources recommend less than 75 years simply because of the differences in the practice patterns. Now, less than 10 years donor corneas may have a good outcome, and we may do these corneas use these corneas also for lamellar dissection, but dissection can be somewhat a little challenging with these donor corneas because of the inherent elasticity of the tissues. Microkeratome versus manual dissection, there's not much of difference in terms of visual acuity recovery, but in terms of the quickness of the recovery, there may be certain differences because the microkeratome tends to give a little smoother cut, and there is an advantage of having a greater consistency and more accurate donor thickness measurements with the automated dissection. The nomogram is followed at the IBank to have a somewhat very regular kind of cuts, and ideal for use is 90 to 120 microns because of the ease of handling of the posterior lenticule. Now, when we looked at when the IBank is involved in doing the pre-cut, what is the test, what is the variability? So majority of the lenticules which were prepared were in the range between 101 to 150, which is acceptable. And there was a good correlation between the pre-cut and the post-cut ECD when we did the study in over 1,000 plus donors. So it is important to look at the parameters. One of the important things is the graft thickness and the graft dimensions to plan out the surgery. And if at all marking is required in extremely thin corneas, one can do that at the time of surgery. With respect to DMEC, we know that the DM characteristics are very much related to the age of the donor. There are changes in the Descemet's membrane which occur with age. Younger donors tend to be thin and DM stripping can be difficult, and these are also elastic. So surgical manipulation during the surgery can be difficult. Older donors, on the contrary, can be brittle, they can be less elastic, and sometimes may not even form a scroll. So sometimes it becomes important to mark the older donors. Older donors, the donor age ideal for DMEC would be 40 years and above. Ideal would be between 50 to 70 years with respect to the nature of the surgery. Now, when we do a DMEC donor preparation, the corneas with Descemet's membrane properties that are difficult to peel usually come in mated pairs. So if you're finding a difficulty in stripping one pair, it is important to rule out the other cornea also for the DMEC preparation, because this tissue may also give a trouble because of the dense adhesion. So this is important factor to look at when we are planning for paired cornea for DMEC. Corneasol versus MK preservation. Cornea is compactor in corneasol, and corneasol is also somewhat little sticky in what we observe. So it is important to risk the donor cornea in corneasol before preparing the DMEC tissue scroll, and it also helps to warm the tissue before donor preparation to let the tissue be little swollen at the time of tissue preparation. Now, since we are also providing pre-prepared DMEC from our IBank, now there are several questions which come up about whether we should give a complete scroll prepared or whether it should be just good enough to have a pre-stripped tissue. Now, what is the ideal? This is one question which we will face from the corneal surgeons. And the other second question would be, what is the ideal prep to utilization times and the ease of use? And what are the outcomes of IBank prepared tissues? Now, with respect to what is the endothelial cell viability of the eye-bank process, DSEC and DMEC grafts, for DSEC, the evidence says it's around 7 days, though we may not go up to that time, but this is the largest duration up to which, when we have a DSEC tissue, can be used up to 7 days. For DMEC, the evidence is for 4 days' time. What are the effects of transportation? Although we say that there's no effect on the endothelial cell loss with respect to the duration up to 7 days, but sometimes the practical situation can be the anterior lamellar cap can be dislodged and the centration marks tend to become fainter with time. So in conclusion, keratoplasty outcomes are dependent on the donor parameters, and continuous research and investigations into eye banking practices will impact and enhance the success of keratoplasty in varied clinical situations. Thank you for your patient hearing.
Excellent overview and practical points, very relevant for corneal surgeons. There's very little time left, and I was going to cover managing limbal stem cell deficiency. I'm going to go over it very quickly. Now, we know what are the various etiologies of limbal stem cell deficiency and what are the clinical features. A diagnosis is predominantly clinical, and the basic changes will be vascularization. Slides. Okay. So vascularization of the cornea appears dull and irregular, and the patient will have an uncomfortable eye. So the key features are the conjunctivalization with opacification and disruption of the palisades of Vogt. Impression cytology is not essential. It would be more required if you were doing a particular study. Basically, you're looking for evidence of conjunctivalization of the cornea by the presence of the goblet cells. We standardize the technique if you're going to have the impression cytology done by an external lab, where depending upon which area you're taking the specimen from, you have different shaped filter paper strips so that the lab knows which is the area from the limbus, which is on the cornea, and which is on the conjunctiva. In certain situations, there may be goblet cells absent everywhere on the conjunctiva as well. So that is why it's always good to have a control. Now, you have to assess whether it's unilateral or bilateral, partial or total, what is the vision, what is the visual problem the patient is having, whether it's uncomfortable, and whether the eye is inflamed or quiet. This is important because doing any limbal stem cell transplantation procedure in an inflamed eye is unlikely to succeed. So it's very important to try to get the eye to settle down. And often you will find just by tear substitutes, phonics reconstruction, controlling of the lid abnormalities, and controlling the inflammation, the cornea may clear up and the patient may get reasonable vision. And if that doesn't succeed, then you have to go for a procedure to restore the stem cells, with the concept that when you're replenishing the stem cells, the environment or the host environment has to be conducive. So you require adequate lubricants, we require a stable surface and a healthy substrate which is not inflamed. So you have a conservative do-nothing approach, and if it is unilateral, one would do an autologous stem cell transplant. If it's bilateral, then you're looking at an allograft either from a relative or from a cadaver, or you could consider of non-ocular sources such as the oral mucosa. Now, looking at a conjunctival limbal autograft, it is similar to what you do with an autoconj transplant for a pterygium, and it can be supplemented with adjuvant amniotic membrane transplantation. Bilateral cases you can take from a living relative, and there is a risk of rejection, of course, so you do have to use systemic immunosuppression. We have looked at the clinical results of live-related transplants. This also does well. So if you have a bilateral disease, you can use a live-related transplant with meticulous care, close follow-up, and a titration of medication. All techniques actually do give good results. So it's just a question of how you recruit the patient and do the careful care in follow-up. This is another example of a live-related allograft, and here again, remember to counsel the patient. You're not going to be able to get the eye exactly as it was before you had the injury, but what you're aiming to do is improve it from how it is. So there would be clinical improvement in vision, patient comfort, as well as clarity. And we have compared live-related allograft versus a cadaveric stem cell graft, and we felt live-related allograft allograft was better, but this is not to say that a cadaveric graft doesn't succeed. That can also give good results. It's just that you require more systemic immunosuppression. So this is an example of cadaveric limbal stem cell transplant, and here's another example of a cadaveric keratolimbal transplant. So allografts, as we see, the evidence shows that it is a better option if it's live-related in terms of early reepithelialization, earlier visual rehabilitation, and better visual outcomes, and lesser complication, less rigorous follow-up. These are the examples, as I said before. Both procedures do give good results. If you compare both, you would say as a good outcome at 6 months. One benefit of a cadaveric allograft is you can take much more tissue. So at one go, you can do an annular corneoscleral allograft. And the other way of achieving this is by doing a large diameter LK. This is particularly useful if you have a thin cornea, and at one stage you are able to restore the stem cells as well as restore the vision. This is the technique of large lamellar keratoplasty. It is a manual technique. And then you come to the concept of cultured limbal stem cells. Here you can harvest them from a cadaver or from the other eye if you're planning autologous. So CLET adapted technology in Indian setting to have less expensive interventions. And again, it has been shown in various scenarios that you are giving now a confluent sheet of cells. At one go, it is supported by autologous serum human amniotic membrane and using a cGMP facility. So the CLET journey from bench to bedside, it is confirmed that the cells can be cultured, they can be transplanted, and the patients we have operated have later on gone on to have DALC, and the nature of the epithelium has been found to have been corneal in characteristics. So cadaveric allografts can be used to grow cells as well. So you can use a cadaveric CLET. And autologous, if you look at the donor side, it's not that it produces any harm, but it takes about a year for the donor side to heal up completely, and the palisades of Vaux reconnect, and it becomes completely restored to how it was before. So this is another example of a confluent sheets and autologous and unilateral chemical burns. Now the post-op care is important. So actually you have to be very careful. You may have to give steroids for a little bit longer. Beware of steroid-induced glaucoma, and sometimes you may have to also support it with cyclosporin A or topical tacrolimus. Systemic immunosuppression is a very extensive regime with 3 medications: oral steroid, a lymphocyte inhibitor, which could be cyclosporin or tacrolimus, and an antimetabolite, which is azathioprine and mycophenolate. So this is one big negative against allografts. Then failure, there could be various causes. There could be rejection, there could be late failure due to sectoral conjunctivalization, dry eye, and so on. Clinical features of acute rejection, this is not so much relevant for autologous. Not at all relevant for autologous, but it is important for allografts that you need to be very careful. Look at the lenticules, look for any epithelial rejection lines or any melting and epithelial defects. For treatment for rejection, usually topical steroids is useful. You can even do subconjunctival or subtenon steroid and systemic therapy. So the long-term success can vary from 0% to 75%. Strategies to improve the long-term success can be preoperative, intraoperative, and postoperative. We've done there's a systemic review by Dr. Basu et al. Looking at autologous limbal stem cell transplantation, a review of clinical outcomes with different surgical techniques. They did note that in the absence of RCTs, the best evidence would suggest that SLET is a little bit better than CLET. Another systematic review that our team had done had looked at all surgical outcomes for the treatment of limbal stem cell deficiency. And here the question was that the anatomical success rates are more or less similar with no statistically significant difference. However, the functional gain was better with SLET as compared to keratolimbal allografts than CLET. But here again, we did not find any RCT. So this is a systematic review of non-RCTs, and there could be a lot of variations in the patient selection and protocols. So just to go back again, if you look at the direct lenticule applications, fibrin glue helps to augment the technique. It was a very fiddly technique earlier, having to suture with tenno nylon, but fibrin glue helps to stabilize it, and you can do autologous clet as well. And so therefore, looking at unilateral comparison of the various options of autologous limbal stem cell transplant, a direct limbal lenticule versus a slet versus a clet, and you will appreciate that they all have good results. So it's a question of what is convenient to you and what is suitable for your patient. So ocular surface reconstruction, one example of a surgical video, thermochemical burn. If we have time, I'll show it. I'm sure all of you already know how to do the surgery. Basically, you release the symblepharon very carefully. Be careful not to damage the underlying cornea. Sometimes when it's not visible at all like this, there may even be a perforation underneath. So UBM as well as ASOCT preoperatively can be helpful. So very gently dissect out. Try not to use a very sharp dissector. Sometimes you can get a very easy cleavage plane and the whole thing comes off very smoothly, particularly if the patient had been initially treated with amniotic membrane in the initial phases. But sometimes it can be very irregular, particularly if they're molten metal. So you have to be very careful, very patient, and release all the adhesions, and then remove the superficial pannus and then apply the cultured cells. In the interest of time, I will not show the entire detail. It is similar to what Dr. Lomi showed because the cells are grown on amniotic membrane, and fibrin glue has made the surgery much easier. I think we're over time. So this is the first day post-operatively. If there's a little bit of hemorrhage underneath, it doesn't matter. As we'd shown earlier as well, it clears up. And so the choice of topical steroid, you can use a milder steroid if it's autologous. And 3 months post-operatively, you can see that the patient has done well, and with a contact lens can gain 6/9 vision. The donor site heals in 1 to 2 weeks and takes 6 to 12 months to replenish. So I'd like to acknowledge the stem cell facility at AIIMS, and Dr. Sujata Mohanty is the professor in charge, because they've taken a lot of the headache away from us in having to prepare the membrane in the eye bank and the various supports for all the culture work, etc. And with that, I'd like to thank all the speakers for having taken such efforts in preparing wonderful talks, and also the audience for having attended. I think we don't have time for questions, but you can email us or call us by phone if you have any questions or any discussion. Okay. Thank you so much. Thank you. Right. We'll just take a group photograph. Huh?